So yes, I'm here today to talk about safeguarding and medication, and when Elka asked me to come along, I did kind of struggle a little bit to think about things that I could talk about, and kind of reflected on the things that we're sort of contacted about in the safeguarding team when we think about medication. And it is mainly around medication errors, or when medication is potentially being used to control someone or to coerce someone, or isn't being administered properly in the way that it's prescribed and things like that. So I am mainly going to cover medication errors. Just a bit of legislation and guidance that we use as frameworks to help us. So we've got the Care Act when we're thinking about safeguarding. We've also got the Children's Act, which for some reason I've not included. I need to click the next button. There we go. I haven't included the Children's Act on there, but obviously very important as well, because I am thinking about children and adults here when we talk about medication and medication errors and safeguarding. But then we've got the Mental Capacity Act and the Mental Health Act, NICE guidelines, any CQC guidelines that we might need to think about when obviously a lot of the people that we support might be living in residential or nursing care, and the Health and Social Care Act as well. So under the Care Act, all agencies have a legal responsibility to raise a safeguarding concern when there's cause to believe that that there's an abuse of an adult with care and support needs, which may occur as a result of neglect or an omission of care. And then when we're thinking about the Mental Capacity Act, we're thinking about best interests, deprivation of liberty, safeguards, and all those sorts of things. In nursing care residential settings generally tend to have their own frameworks and procedures for managing medication errors, including when you should raise a safeguarding referral. Lots of safeguarding adult boards have got that guidance on their local, on their pages. And interestingly, we didn't really kind of have a lot of calls around medication and guidance around that until the introduction of the Care Act. And then since then, we've had lots and lots of calls around medication errors and kind of when one needs to save it, lots of referrals around medication errors. So I think that's kind of what's led adult safeguarding boards really to kind of develop their own processes and procedures to guide care homes and things like that when we're thinking about medication, to kind of stop people making safeguarding referrals to think about their own processes and frameworks that they need to follow before we reach that point. So, medication errors. So the National Patient Safety Agency defines a medication error as an error in the process of prescribing, dispensing, preparing, administering, monitoring or providing medicine advice regardless of whether any harm occurred. And the World Health Organization defines a medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. So the main safeguarding issues, and it's important that I make this distinction for adults, is when they have a need for care and support. This isn't just any adult, it is an adult who has needs for care and support. So that can be a mental health need, it can be a learning disability, it could be a neuropsychiatry need, a substance misuse need, it could be a variety of different things really, but for context with adults, it is adults with care and support needs when we're thinking about safeguarding referrals. There's a number of reasons why medication errors might occur or medication incidents might occur, and there's just a little bit of a list there. I don't really need to go through them all. Human error is an enormous one, isn't it? We are only human, things happen, and as long as we've got the right frameworks and things to look into why that happened, and try and prevent it from happening again, consider whether any additional learning or training is needed to support that person that's been affected, or to support the person that's kind of been involved in administering the medication. It is all about learning and support, isn't it? But we do need to think about when things go wrong as well. And not all medication errors are safeguarding concerns. Mental capacity, I'm not going to go through in too much detail, but any adult, I suppose, any adult with capacity to make a decision on medication has the right to refuse medication. Now, I'm going to talk a little bit about covert administration of medication, because again, if it's given covertly, and that could potentially indicate a safeguarding concern, couldn't it? It needs to be properly assessed by the right kind of multi-agency, things like that. So if an adult lacks the capacity to consent, then we need to make a decision around whether to go ahead with treatment in that person's best interests. And there are many important elements involved in trying to determine what the person's best interests are. So that's things like considering whether it's safe to wait until that person can give consent, if that's likely to happen, involving the person in that decision as much as possible. Trying to identify any issues the person would take into account if they were making the decisions for themselves. So that can include sort of religious or moral beliefs, and that would be based on the person, the views of the person expressed previously, so thinking about what they previously would have wanted, as well as any kind of relatives or friends or anyone that's kind of close to them, next of kin, things like that. And of course, if there isn't anyone that is suitable to help them to make those decisions, then we need to be thinking about a referral to an independent mental capacity advocate. When we're thinking about covert administration, it's only likely to be necessary or appropriate when an adult actively refuses their medicine. They're assessed as not having capacity to understand the consequences of their refusal. I'm not moving on with the slides, am I? And the medicine is deemed essential to that person's health and well-being. So I know in the past, you know, when I've worked, it's a long time since I've been clinical now, where we've thought about giving medicine in yogurts and things like that, and that's fine, but it's got to be properly assessed, and you know, kind of a decision made by the right people around to supporting that person involved in that person's care. Otherwise, we need to be thinking about making a safeguarding referral for that person if it isn't properly assessed and it isn't sort of, you know, routinely and thoroughly reviewed and those sorts of things. And obviously that it's only something that we can consider when that person lacks capacity and as a last resort. So NICE guidance indicates that the safeguarding issue in relation to managing medicines can include the deliberate withholding of a medicine without a valid reason, incorrect use of a medicine for reasons other than the benefit of a resident, and deliberate attempts to harm through the use of a medicine. So again, it's important to remember that when we're thinking about adults, this relates to adults with needs for care and support. For the purpose of making a decision around whether you need to do a safeguarding referral, if it's that there's evidence really that medication now has had a significant impact on that adult, and there isn't really kind of a definition around what harm is, I suppose, but I suppose if it affects someone and means that they require additional care and support, then that potentially could mean that that harm has occurred. So when we're thinking about the circumstances where we might be thinking about whether or not safeguarding referral is needed, so there's kind of four main areas really, I suppose. So that's when there's been the death of an individual, there's been injury, when a person has experienced harm or potential harm, and is kind of causing impairment to health, which means that they need that increase in care and support. There might be abuse or an allegation of abuse for someone that's in a position of trust. And there might be a crime, which means that the police might need to be a referral to the police, and that can kind of happen through making a safeguarding referral when there's that discussion then with the MASH for everyone that's kind of familiar with that process. And there might be a number of reasons. It might be in terms of abuse. It might be that people might be left without pain relief, which results in a prolonged period of pain. There might be significant deterioration in physical or mental well-being because of missed medication. There might be additional or significant emotional distress, elongation of an illness because medication is not being given as prescribed, the inappropriate use of PRM medication. There might be the same drug that is repeatedly omitted, which has caused deterioration in physical or mental well-being. And also use of medication to control behaviour or restrict the individual or sedate them. They are generally kind of the calls that we have into the safeguarding team when we've got people that are on medication at home and they're being cared for by a relative or a friend, and actually their symptoms are quite difficult to manage, and so the carer or the friend or the relative is kind of overdosing or overgiving medication, I should say, which is then sedating that person. So just a few more, I suppose, getting to click. So again, thinking about when medication is given as a form of unlawful restraint, a deliberate act or to administer or neglect to administer medication contrary to the directions of the prescriber. Medication administered covertly where there's been no specific approved covert medication protocol, consecutive or multiple medication incidents involving the same person, or just a single incident whereby there's been a lot of people kind of involved and there's a significant risk posed to that person or the person that's experienced that harm. where a controlled medicine is involved and there's been harm or a crime potentially, and where a referral is required to a professional body. So I've just got a couple of case studies. I don't know if anyone's kind of got any comments around sort of how they would approach this. These are real case studies that I've chosen. There's only two, and they're quite different from one another. So this lady is a 35-year-old lady with background of schizophrenia. She's admitted to an inpatient psychiatric ward under Section 2 of the Mental Health Act. She's been stable on a prescription of clozapine for several years, which is closely monitored in the community. Whilst on the ward, bloods are completed, which reveal elevated levels, assay levels. The lady tells you that her partner has been helping her with medication, and it transpires that partner has been administering extra doses of clozapine at times when the patient is hearing voices. Partner is also refusing for further assessment of the patient at home to enable a safe discharge home from the ward. So is there anything else that we need to consider that anyone can think of? Are we doing a safeguarding referral? What are we doing? Are we having further conversations, and who are those with? Yeah, absolutely. So we need to have that further discussion with the partner, don't we, to understand why potentially that's been happening at home, and has the partner told anyone about it? Has he communicated this to the lady's community mental health team, that actually she's been experiencing symptoms at home, and can they help, and all those sorts of things. So if we're having a conversation, if partner isn't forthcoming and partner's quite obstructive, do we think maybe then we need to do a safeguarding referral? Yeah, absolutely. And I suppose I need to add here as well that the lady was quite reluctant for us to have any conversations at all with partner. She was quite worried about the impact. She was worried that he would leave her. He's my only carer, he's the only person that I've got in my life. So it was quite a careful approach that we needed really, in terms of trying to balance her wishes and feelings against the risk, which is often what we find, isn't it? But yes, partner did warn. And he did allow some assessment at home, and she was re-established on clozapine and was well, and she went home. So it was all good in the end, and there wasn't actually any need for any kind of Section 42 safeguarding inquiries or anything like that, which is positive. And then case 2, we've got Tim, who's a 27-year-old man with a learning disability and epilepsy. He's admitted to hospital by ambulance following an increase in seizures at home, where he is looked after 24 hours a day in a nursing placement, and his place there is authorised underneath the DOLS framework because he lacks capacity to consent to his care and treatment. He's treated with sodium valproate, and the ward noticed that he's been administered an incorrect lower dose of his medication on 4 consecutive days. What do we think we're doing in those circumstances? So Tim isn't able to verbally communicate at this point either because of how unwell he is in hospital. So speaking to him isn't really an option. Okay, I'm struggling to hear, but I think you're saying yes. Yeah. Sorry. Yes, it absolutely is a safeguarding referral. We've got an extreme increase in this man's need for care and support. He's in hospital, he's really poorly. You know, this is medication that is really vital to treat a really serious condition that potentially could be fatal. So yes, absolutely do need a safeguarding referral. I suppose it's important to remember as well that there is a referral process that we can use in extreme cases really, where abuse or neglect of an adult has resulted in really significant harm or death. Called the Safeguarding Adult Review, which is a statutory process that we do under Section 44 of the Care Act. And there aren't many safeguarding adult reviews, and I did struggle to find one actually when I was doing some research for this presentation. But there is one where a lady was misadministered a medication for several days and did sadly die, and the person that administered the medication was arrested. So it is something, you know, although thankfully, touch wood, doesn't happen a lot, that, you know, it is something that we need to be really, really kind of mindful of, that actually it could happen. So it's really important that, you know, we are making sure that, you know, things, MAR charts and things are correct, and that people are familiar with how to administer medication, all those sorts of things, so that we can avoid cases like this. So when you're raising concerns, we're speaking to the adult if that is possible, and they have capacity to engage in that conversation. We're speaking to the care provider and sharing your concerns. So quite a lot of the time, if we're working with someone who is living in a long-term kind of residential or nursing placement, that we're having those conversations with the care setting. We're having oh, I've noticed this and I'm a bit concerned, and can you perhaps just tell me a little bit more about it? There's no harm in doing that at all, and we would actively encourage you to be having those open conversations. We wouldn't be advocating at all that, you know, you come in kind of back and raising a safeguarding referral without having that conversation first around what your concerns are, because they need that opportunity to kind of look and see, oh, what went wrong, can we look into this further, and then kind of provide a little bit of reassurance really around some of the things that they've implemented to prevent that from happening again. It doesn't always need to be a safeguarding referral. You can also raise those concerns that you've got in your MDT to determine if any other practitioners within your team have had safeguarding concerns about that particular provider before, or that adult. And you can always gain advice and support from us in the Trust Safeguarding team. There's a few of us. There's myself and Laura and Sam in our team who you can contact, and that's our office number. We're also really available on Microsoft Teams, so if you just pop us a message or send us an email, then we're more than happy to provide advice where needed. This is just a flow chart that I got from, I need to go back a slide actually, reporting. Yeah, so calling 999 in an emergency, reporting to the police if a crime is suspected, completing an incident form on Ulysses, which then leads you to complete the safeguarding referral if one is indicated, which we then send off to adult social care, and then also thinking about contacting the CQC, that might be required. This is just a nice flowchart that I found in our Staffordshire and Stoke-on-Trent adult safeguarding medication guidance that's on the board. I'm getting confused between the laptop and the clicker. So it just kind of, it's small there, isn't it, on the screen, but kind of tells you all the circumstances where safeguarding referral might be needed, or it might need to just be an incident report. So there's sort of a few scenarios there, but yes, if ever you need further advice, or you're sort of thinking, not sure, then give us a call. I'm more than happy to go through anything. If it isn't a safeguarding concern, then, you know, we'll try and help you find the right way to deal with it, or the right kind of advice to sort of try and manage it. And these are the numbers for adult social care if you need to ring and make a safeguarding referral, or if you just need to refer an adult for further assessment under the Care Act. It's a bit of a whistle stop there, so thank you everyone.